Hi, everyone, and thank you for staying late. But this is the most interesting part of today's meeting. Robert Chihak and myself are going to moderate the live cases. And we have 3 VT cases and 1 AFib case, 2 cases done at Homolka and 2 cases in IKEM. The cases are, the first case from IKEM is a CT-guided catheter ablation for ischemic VT, and that will be done led by Pierre Jais. The second VT case from Homolka will be a Guidewire mapping of an LV summit PVC. And the third case in IKEM, the third VT case, will be VT ablation guided by deep mapping. So it's all of these 3 cases are a continuation of the lectures that we had before this break. And the last case will be from Homolka, an AFib case done with the Affera technology that combines a focal ablation with PFA and RFA. Now, we're going to go through from one lab to the other. We'll start with, I think, IKEM, right? We'll have 25 minutes per each lab for the initial session. And then we will go back to each lab after the first rotation for another 10 or 15 minutes. This is an interactive session, so it's all for you. So if you have questions, please ask those questions and we'll convey them. Yes. To the operators.
There are ladies with microphones, so you can ask during. Yes. Yeah.
So I think it's time to go to the first case.
Yes, please, can we go to the IKEM lab for the first case, Garcia case? Can you please introduce the patient and tell us what you did up to now?
Yeah, maybe from the motion of the patient.
1 second, Pierre. We can't hear
so well. Could you show me again the pulmonary artery?
Yeah, he's probably moved. We need to see if these 2 maps are... Nehýbejte se.
Draku, slyšíte nás?
Ano, slyšíme se. Dejte nám chvíli ještě, jo?
No, you can start just now.
If there is a possibility that somebody else will start, will be better, because we have some problem with movement of the patient and shift of the map. So it will be better if you can switch either to Peter or to Homolka for the initial part.
Okay. So maybe in Homolka, do you hear us?
Okay, so we will introduce the case. Pavel Hall again is expert to introduce for introduction. So he will introduce you a young lady with the first case. Okay, go ahead, Pavel.
So hello, this is the live case number 2, and here's the history of the patient. It's a young female patient, 31-year-old. She suffers frequent monomorphic PVCs since 2017. And the main symptoms include palpitations and fatigue. The patient never had a syncope. There are no significant findings on echocardiography. And already in 2018, 4 years ago, the patient was indicated for ablation. In those times, we did a carto-electroanatomic mapping. We mapped the outflow tracts, aortic cusps, and the distal CS. But despite RF applications in these locations, we only saw transient effects. And there is a very interesting part in the patient's history. 2 years ago, in 2020, the patient got pregnant, and during the pregnancy, she had completely no symptoms and completely no PVCs. She delivered a normal childbirth, and after the delivery, there was a gradual increase of number of PVCs again. On the 12-lead EKG, you can see here how the PVC looked those 4 years ago. Those PVCs... Oh, you don't see the presentation?
Okay, now yes, okay.
I guess this is the thing.
I hope you can see the 12-lead EKG now. there is the PVCs on the 12 lead EKG now with inferior axis. I just mention again that this EKG is 4 years old before the first index procedure. The PVCs had inferior axis. There is a negative QRS in the lead 1, and the QRS is more negative in AVL than in AVR. And we see the LBBB morphology. We suspected left ventricular outflow tract origin of this arrhythmia. Now, when we see the EKG from yesterday, from the admission to this hospitalization, we see a similar QRS during the PVCs, but see here the QS notch in V1, which we would suppose to cause the right-left junction, maybe. But also, if I show again the 4-year-old EKG, we must suspect as well different lead positioning during these EKG taking. So here, one more thing on the Holter. You can see how frequent those PVCs were in this lady. There were about 40,000 PVCs. They were not only isolated, but we saw a couple of couplets and also non-sustained VT runs. Okay, that's about the history, and now we can switch to the other room.
Tady jo? Okay.
Ano, vidíme vás, slyšíme vás.
So, okay, so we can start, I think?
Go ahead.
Yeah. So, welcome in our EP lab in Homolka. We are happy to share our experience again after 1 year. So let me introduce, maybe it's not necessary to introduce, Garcia. It's our special guest, and he will perform the procedure of this ventricular ectopy. So,
thank you very much. You started with the description of the case, and we can start with the way we approach this. So, suspect some sort of LVOT, PVC, maybe LV summit. You can put the live screen if you want to show that the patient is actively having PVC. So we have the benefit, we have the benefit of mapping, which is very helpful. So we're working on putting the screen. There you go. So you can see that we have PVC. So as I described on my talk, our first approach is to start with the venous circulation. So show just the fluoroscopy, please, and show the first cine we took. We gained access into the coronary sinus. Can you put the fluoroscopy, please?
Mm-hmm. Review.
But put it on live. Just 2 seconds. So we started by obtaining access into the CS with large curve fragilis. You can see it's a very young patient with a very extremely vertical heart. We took a first picture with a wire because the wire, you can see, was not going easily. And we can see that there is a tight valve of Busen's before the gray cardiac vein empties. Just do the LAO. We see that there is a nice gray cardiac vein and an AAV. You can see that there is no good septal branches. We have some collaterals going through a posterolateral branch, but in this case, what we're left with is indirectly mapping the epicardium with a catheter. So we use the mapped catheter and we place it in the AIV and the gray cardiac vein. I think I saved a picture. You can say the next one. The next one. It's better. Yeah. So here you have now, we tried to see if we had any good septal branches. There's 2 distal septal branches, but there really is nothing coming down. By definition, the top of the AAV gray cardiac vein is the LV summit, right? It's the highest point of the left ventricle. So once we have this information, we go to the electrogram screen. Let's go to the electrogram screen right now and update the screens, Stefan.
They are both there.
Yeah, but I don't want the signals of the ablator. Just update now and show without the ablator, because this is the first step. So the first step of the procedure is we say, okay, what we have today is just a catheter and the AIV and the gray cardiac vein. We have PVCs, and the question is it true LV summit, meaning subepicardial or not? Now you can see here that the signal on 5, 6, and 7, 8 are equally early there, but not really super early, although maybe minus 10 milliseconds or so. When, in my opinion, when you have something that's truly, truly LV summit, you are minus 30, minus 45 in the AIV gray cardiac vein. This at most is 15, maybe if you're generous, 20. So there is a suggestion. It's getting earlier to the epicardium. Will this work from the endocardium? She has very small circulation. And what are we left to do? So I want to briefly... Yeah, no, now I can.
Can you show us the
yes.
12 lead ECG of the PVC? Can we just go over the 12
Today? Sure.
Yeah.
Right. So you have a left bundle, PVC. Initially looks negative in lead V1. There is a small R wave in lead V2 and RS, a bigger in V3. It's inferior axis, so we know we are in the outflow tract, and because of the early transition, we suspect it's left ventricular outflow tract, not right ventricular outflow tract, and it's structured what we call to the left of the midlane. It's RS in lead V1, so there's a small R wave in lead V1, and it's more negative in AVL than AVR. So in my opinion, this goes to that general area of what's so-called being called LV summit. The notch in lead V1, Stefan, can you gain lead V1 a touch? Just gain it a touch. Yeah, you can see there how it becomes negative and positive in V1. This is a sign that sometimes we have thought potentially something right in front of the aortic valve in that triangle between the right and the left coronary cause called the right-left junction, but that's right opposite to the pulmonary artery and the epicardium. So it's somewhere in the LVOT. I couldn't tell you just based on this, because this is not my practice to just say it's epicardial or not. This guides me to the area of the aorta, LVOT, endocardial, and epicardium aspect of the LVOT and the pulmonary artery. So based on that, that's when we started the next step, which was putting catheters in the coronary venous circulation and mapping the coronary venous circulation. Any questions, Ellen? Should I continue or?
You can continue for me. You can continue.
Okay.
Okay.
So I want to then show you what we did. So we started mapping the endocardium, and we can show the map around. I'm going to just maybe do some of this live. We're using an ACT of 360 and retrograde. We have the ablation catheter in the outflow tract now, and we have a long sheath, an SR0 to support our catheter. So if we start mapping here, just for matter of presentation, I would like to show eyes, okay? So you have a very vertical heart, that's the tricuspid valve. Right now here, I'm showing the tricuspid valve on the right coronary cause and the pulmonary outflow tract, the RVOT. As I clock here, I'm gonna open more of the left ventricle. You can see here now my catheter in the top of the left ventricle. That would automatically make this the left coronary cusp. Behind is the right coronary cusp. In front of everything is a circle. That circle is the pulmonary artery. And then there is some tissue between the pulmonary artery, the left coronary cusp, and the endocardium. This is the long axis view. Very nice view for her because she has a small vertical heart. By doing anteroflexion, I advance the tricuspid valve. I'll try to show you short axis. You can see here now the short axis view, and we map everything in the LVOT Here, that's in front of the aorta and the mitral valve. For example, if I counter the catheter, I put it closer here to right below the left coronary cos next to the mitral valve. So you can see now on the live screen, we did, in this sense, endocardial point-by-point activation mapping. And there was nothing really dramatically early. That means that this is not necessarily going to be, and it's not, a subendocardial source of the PVCs. So we then completed our map looking at the opposite structure here, which is the pulmonary artery. So we went to the leaflet, that is the septate leaflet on the pulmonary artery. It's this view on ice, in which you see that white circle on the center. That's the top of the left ventricle, that's the pulmonary artery. You can please show the last fluoroscopy that we saved here, please. In the last fluoroscopy, I will show you how we get into that area. And that turned out to be a nice signal. Stefan, put the signal we had from the RVUT in the pulmonary artery. Here. So you can see the catheter here in the pulmonary artery, and then we save, yeah, that's the signal we obtain mapping above the pulmonary artery. You can see the correlation.
Asi bílou dejte. Tak tady trošku níž. Tady je bílej.
Yes, we are already out.
No, okay.
And make it away.
So you can see that signal in the pulmonary artery. It's almost on time, and that fits the fluoroscopy there. So you can see that we are on a space in the top of the left ventricle, more medial than the AIV. Yeah, you can see that on the review screen. It's a review screen, okay? Here we couldn't capture at all. That's the live screen. You had it before, in the prior when you had it.
Okay. So do you see it better now?
But that's the live screen. You had it before on the review screen.
Fermin, can you take us back?
I just wanted to show. Can you take us back? We're trying to take you back to the pulmonary artery, but there is some delay on the transmission here. So that's now live screen. And that's what I was trying to tell you is that we map also the opposite side of what the LV summit, that this is one way to get there. Okay. Here we cannot capture because we're in the pulmonary artery, and with endocardiac echo we show the close relationship to the LAD. Now I will show you. Can we go to the prior view you had that had everything? Has the eyes. Okay, there, you see a lot on the right side. Don't touch it, please. On the right side, you have the review signals. Oh, they're just moving. Yeah, just click that, double click. Double click that. Double click RVUT. There you go. That's the signal on the pulmonary artery, you see? No, stop, yeah. That's a signal on the pulmonary artery, which is not bad. But you can see it's QS. We tried to paste here, you cannot capture, but it's on time. So this puts us somewhere enclosed in that space between the pulmonary artery, the left ventricular outflow tract, and that's the epicardial area of the LV summit.
Fermin, can you show us in the
so
map?
we decided.
Can you show us in the cardo map which structure is, where is the pulmonary artery there?
Yeah, can you show right there, that little circle I draw there for you. You see that? Yeah. Turn it around so they can see it. Yeah. Turn it around the other way.
And it looks like activation right there is later than activation in the LVOT?
Well, because now we redefine the activation in the LVOT, but before that looked earlier before we redefine. Because you can see right here on ice, you see the ice view live, that's the septate leaflet of the pulmonary valve, that's the left coronary cos and the right left junction. So if you put a catheter right below there, that's how close you're going to get. But when we now redefine things from the left side, we now show you a different map. This is the final map.
So just to make sure that we understand it right, so the cusp area, the LVOT area, seems to be the earliest so far from what you have.
Well, it's on time. Remember, with CARTO, you cannot include the activation you have in the decapolar catheter. So yes, this is the earliest of what we have mapped that we can integrate on the map. If I show you activation from the CS, maybe it would look earlier in the CS, but I cannot integrate that into the map. So of the points available, all you can say is that the earliest seems to be here, where I'm showing you now, in the endocardium. But you cannot integrate into this map the signals from the CS. Now, because I'm showing you live now, you can see live, this is the best spot on the endocardium, and you can compare to the CS. The CS is still beating us for a little bit. Okay, just update now, please. Put it on the live screen. There you go. So that would be our best spot on the endo, and the CS is slightly earlier. Right. Okay? And this is the best we can get. So it seems like we have something in between the epi, which is not a bad signal, and the endo. And we triangulated on eyes. You can see here the three things. You can see the left coronary cusp, the tissue right below the left coronary cusp in the long axis view, with my catheter there and the pulmonary artery on the other side. Okay? So our plan was to start delivering RF here, because this is the closest we get from the endocardium. So there's two ways to access that. One is this way, with the catheter coming down. The other one is with the curve, which should be this other way. Like that. So you have to find out which is the one that gives you the best contact. This is with the curve, right there. Okay? And that would be the two approaches. So this is what we did so far to get here. I tried to summarize the best I could.
So where are you exactly trying to get? Like
right now, I'm below the left coronary cusp in the right-left junction with the catheter bent upside down. You can see on fluoro here, okay? And I can do this. I get a better sense of contact this way. This way, I get a better sense of contact.
If you guys want to ablate now, before we have to move to the second lab, that would be a good time.
Okay.
Any questions?
And maybe you can also share with us what ablation setting you're going to use when you are trying to make a deep lesion.
Wait a second, because I fell off of the left coronary cusp. 40 watts. Okay.
Budeme ready na ablaci, jo, za chvíli.
You have a good contact there now. The vector looks good.
Okay, this is the spot. Okay. Put the screen at 50, please. Okay.
So good contact?
Yeah. Go ahead. 40.
So let's start?
Yeah.
Go, jo? Aplikace. Vydržte, jo?
Jaký budete mít parametry ablace?
Okay, you can see there PVC suppression.
So we have 40 volts.
Monitor eyes all the time to make sure you're below the valve. You don't want to come above the valve here. Did I come above the valve? No.
Is he ablating now?
No, there's no ablation.
Are you ablating now?
Yes, I do.
You are ablating, right?
Yeah,
Yes.
of course. We're done.
Oh, just pressure.
What do you think?
Maybe pressure alone.
Can you comment us what you are doing now? You are ablating. What are parameters of ablation,
we decided
please?
to ablate because you guys asked us. We did 40 watts right below on intracardiac echo. You can see right below the left coronary cause without a curve. It's opposite to the pulmonary artery, and it's where we triangulated the best side of ablation right there. It's on time with the CS, maybe a little later than the CS, but anatomically it's very close. This is where a septal vein would be if existed. This patient doesn't have one. The key here is good contact, so we're using, you can see, a long SL1 to keep the catheter on the aorta in good contact, looking at the contact force and the vector of orientation up all the time.
Can you show X-ray?
And on eyes, you can see the orientation of the catheter. It's always there. Okay, that's the right coronary cause. That's the left coronary cause, right below the left coronary cause in that tissue.
For me, it looked like you had a fairly immediate suppression, no?
I cannot move anything because, yeah, I cannot move the hands. When you're doing this, you have to keep the catheter there. So just show the beginning of the lesion.
So we have 2 minutes.
Do 2 minutes? Okay, do 3 minutes. Show the beginning. You can see the lesion there forming on eyes. Show the beginning, Stefan, show the beginning of the lesion and see how long did it take to go away. And you can stop at 180. Yeah, just hit a star. You see where the lesion says a star, Stefan? Just double click there. Ablation star, double click there, put it at 10 or something like that. Yeah, there you go. That's beginning of the lesion, so it took 2 seconds or 3. Off. You see that, guys? This is so important. The catheter move up for a second. You're always looking at eyes. Never let your eyes out of the eyes. So your eyes have to be on the eyes. If that catheter moves out of there, your eyes react right away because you jump right into the left coronary cause. That's very important. And pretty much that's it. So we're going to just wait, give a period of waiting, and maybe consolidate a few lesions there, but it took 5 seconds for the PVC to go away.
Yeah. For me, one question before we move to the next lab, you would not expect an LV summit, a deep source, to be suppressed within 2 seconds, unless like you're really close to the surface, right?
This is not subendocardial. This is not subepicardial. This is right in between. If you are subepicardial, you're minus 40. This is minus 10. It's the same almost as the endocardium, so it's somewhere in between. This is not true epicardial. The thing is, because we never mapped the intramural space, everything was called epicardial, and everything was LV summit. And you failed because you would have never ablated here because it's not earlier. But because now you understand the anatomy, you see the beauty of eyes. It puts the pulmonary artery on front, the left coronary cause, and the LVOT. It's the tissue in between. Then you go to this site, because if you have good contact.
Can you show us the signal just before ablation on your ablation catheter?
Yeah,
like
right there. You have it right there on the review screen. Put the review screen, please. Show them the signal before the ablation. No, the signal before the ablation.
Do it on the cardo, if you can, so we can see the unipolar too.
On the carto, show him the signal before the ablation on carto. Stefan, the Pruka is not on the live screen. That's why they cannot see it. Oh, on the second screen, a lot. On the second screen, go back. That's it. That's your signal right there. It's after CS56. There you go. That's classically how it looks. And the key here is good contact.
How early it is?
Do you see it a lot right there? That's the signal.
Do you have the signal on Carto so we can see the unipolar?
Can you show in Carto?
No, but that's the sinus what you're looking at now.
He wants to see a Carto
look
unipolar.
on the PVC bit?
QRS.
A PVC bit.
Yeah. PVC.
It doesn't matter. You can even go like to the earliest where you have the pin there.
There you go.
We are trying to find. Tam poznačený začátek ablace? Tak něco předtím.
Looks good. Do you have unipolar on Pruka? It's after, what do you want to show? An early point
the unipolar electrogram at the earliest point.
You have it right there to your left. That's the uni, ablation uni. It's that one they're highlighting for you. That one.
On Pruka, you mean?
That's the uni. On Pruka, yeah.
And can you put caliber there to see how early it is?
Can you put a caliper on the beginning of the QRS? Put it at 100. I think you see it better. But yeah. There you go. All on time.
Yeah, but you know, at least you don't have an R wave there on the unipolar. So you know, you don't have a steep QS, but at least it looks like it's closer to the endo than anything else because you don't have any wave coming toward you. So I would say it puts you sub-endo.
A million times. It's not early, but it's not early.
Yeah.
So most people would not ablate here because it's not early.
Right.
Okay? So yes, you can analyze the signals, and now that I show you that it works, that's good because you'll help me convince the world. But it's not early. The whole point is you're not finding a minus 30 milliseconds. If we had a unipolar or a bipolar signal inside of the muscle, it would be earlier than everything else, in my experience. But I cannot prove this today because the patient doesn't have a septal branch, and this is the challenge. This would be a perfect case to say, oh, well, alcohol works. Well, how is alcohol going to work if you don't have a septal branch? So you need to understand these techniques and every other technique, and then choose the best technique for your patient. This would be a patient that alcohol couldn't work because there is no septal branch. So your only choice is to do this.
Fermin, thank you for your mastery and excellent case. I'm not sure that you will need the next 15 minutes.
We'll come back and let you know. We will update you.
We will revisit with you later if you have any updates, and we're now going to move to IKEM.
Yes.
Let's just wait 20 minutes, and then we
So
do a couple lesions.
I začnu tam.
Maybe we...
So this is EP lab number 3 in IKEM. I'm here with Dr. Dhanjal, sorry. And we are about to do the deep mapping of the post-MI VT. I would like to introduce the patient first in a very brief manner. So it's an elderly patient with ischemic heart disease after inferior myocardial infarction, after surgical cabbage, and he is a CRTT device for 7 years now. He had a previous ablation about 6 years ago in a different hospital. He has a low ejection fraction, and he has arrhythmia recurrences despite the amiodarone treatment. He had multiple episodes of fast monomorphic VT with the rate of 210 up to 250 beats per minute. Some of them terminated by ATPs, some of them terminated by shocks. And we started in general anesthesia. We are using a transseptal approach toward the LV mapping. We introduced the HD grid, one catheter in the LV apex. We're using intracardiac echo. And now I'll show you what we've done so far.
Yeah, Peter, thank you. That was a great introduction. So if you can all see the N-side X screen, you can see our voltage map. So this is a post-MI patient. You can see extensive septal scar.
Sorry. Can you switch to the N-side screen for the audience that they see the N-side screen? Perfect now.
Yeah, so we can see our 3D map here. So we've used the N-side X HD grid. If we just stay on that septum, you can see the HD grid is in an interesting area where on our BiV signals, we see some fractionation at the end, but nothing really exciting other than that. We look at our substrate map. You can see dense scar regions. You can see a nice channel running right through the center of that scar. And we're just going to show you the late potential map. So we've mapped this in bi-V pacing because the patient's blood pressure was a bit unstable without bi-V pacing. So this is our late potential map. So anything more than 20 milliseconds post-QRS is late. And you can see that with the, can we put the white bar to 0, please? Good. So you can see we've got an area of purple late zone in the middle of that channel. That's highlighted nicely. And what we're going to do now, if we just go back to that's a propagation map showing the late area within the middle of the channel activating late, just where the shaft of the grid is right now. And so in this region here, we thought we'd get some interesting signals. So Sarah, who's our physiologist, has been doing the deep protocol. So if you look at the recording screen, Sarah, can you go back one beat? If you go to the first example, so number 1.
The review screen on Pruka review screen. Okay, perfect.
Sarah, can you click on that? Thank you. Go back one beat. Perfect. So what you can see here is 3 extras at 600, 600, and 300. The VRP was about 280. So we've been pacing, our protocol is 600, 600, and 300. And the 300 has consistently been getting in. We haven't had any issues with the VRP. And what I want you to see on this review slide is the signals in white on the D spline at the bottom. So you can see with the first pace beat, there are late potentials, very sharp late potential signal on that first beat. And what you see with the second beat is that potential either blocks or comes back in. And then with the S3 at the VRP plus 20, that signal decrements even more. And what Sarah's going to do is measure from the near field to the far field between those, the 600 and the 300 beats. So Sarah, can you, not from STIM, can you measure from? Keep going, go, keep going. That's it, beautiful. And that's really nice. So look, we've clearly got decrement of that sharp signal more than 10 milliseconds. So these are real decremental signals. You can also see them on the yellow spline, the yellow B spline as well. So we've been manually tagging.
It's very nice.
Can we go back
you show
one
us
beat?
a sinus beat? Yeah.
Yeah. So the beat before, the first beat on the review screen now is a bi-V paced beat, and there's nothing that's really that exciting. So in that D spline on the bi-V pace beat, you don't see anything late. Maybe something that's within 20 milliseconds of the terminal end of the QRS, but it's only by stressing these conduction channels that we see these decrementing potentials go out. And can we go to the second example, please? You've got to be careful, because if you look at this pacing here, you've got the 600, 600, 300. And just go back one beat, please. Go back. Thank you. If you were to look at this, you would say, right, I've got late potentials on all of my HD grid signals. Can you just put an arrow on the late potential, Sarah, on the first beat? So, yeah, here we go. So these are those late potentials. And on the second pace beat, they disappear. And then on the last beat, it looks like they decrement even more. But this was the area by the hiss. And if we go forward one beat, you can see P, hiss, and V. All right, so you've got to be careful. And we annotate these signals yellow. Let's go to the next example. Numero 3, I think. So when we were mapping these decrementing potentials in this area at the basal mid-septum to anterior septum, we had spontaneous runs of VT, and coincidentally, because we were playing around in the right area, we've got beautiful mid-diastolic potentials already. I would say this is akin to strategic activation mapping. And so we took a 12 lead of the ECG. So you can see the 12 lead on the right, the panel there, and it's positive concordance, but very basal. It's a high-low activation, quite septal. So we started pace mapping around this region. And if we go to example 4, and you can see the pacing morphology here is 12 out of 12. So we're clearly in the exit site. Now, if we just go to the electrograms here, you can see the stim to QRS is quite short. So we are pacing from near the exit site or within the normal myocardial region here. Sarah, just measure the stim to QRS there. We all know Bill Stevenson's work that talks about a stim to QRS of more than 60 milliseconds tells you that you're in the isthmus. And we're just on that. We're on that 60 to 70 millisecond cusp. So we are right by the exit site here.
Maybe we can go just to the work. Explain to us your workflow. So the first thing that you did you do a map during just by V-pacing without the deep, or you started just with the deep map?
Yeah, that's it, Elad. Great question. So when we start the map, we do everything together. So we do substrate and deep mapping right at the same time. So the minute the HD grid catheter is in the left ventricle, we work out what the VERP is with a drivetrain. As soon as we know what the VERP is, we'll do a 600, 600, 300, which is the VERP plus 20. As soon as we've got the 600, 600, 300, that's set. Callum, who is my CP, then records that 300 beat. Callum, can you show that on the N-side X system, how with the 300 beat, we set up a window, so at the end of the case, hopefully you'll come back to us, Elad, and we'll have turbo mapped the 300 beat, which may show interesting late signals more than what the standard late potential map in bi-V pacing has shown.
So you make two maps in parallel, is that right?
Yeah, two maps in parallel.
Two maps
absolutely
in parallel.
Right.
And can you explain to us why you chose 300 as your extra stimulation?
Yeah, so we chose 300 milliseconds. Yeah, Elad, so that's the VERP plus 20. So with the drivetrain at the start, we used the VERP was 280 milliseconds. And so we're pacing at 300 milliseconds, which is what's been published by the Porter Sanchez group and the Bart's group. In the impact VT study that we published, we used 400 milliseconds because one of the studies we're doing is we're looking at, what is the right coupling interval to stress the myocardium at. And I think we probably want to be stressing the myocardium at the same rate as the VT rate. We want to see what the scar looks like as it is in VT. Now, what's interesting with this case, as Peter informed us, this chap's VT cycle length was about 280, 300 milliseconds. So it's coincidental that the VERP plus 20 is, I believe, the right coupling interval to use in this case.
And is the patient stable during the pacing stimulation, or you have some compromise on blood pressure?
Yeah, so with Porter Sanchez, they do a drivetrain of 7 beats and then the extra. Now, what we do is condense that just to a drivetrain of 2 beats and the extra. And you've just got to be vigilant that both of those 2 beats in the drivetrain are in with that single extra, which which they all have been. If you look where I am right now, this is close. We'll just see whether this is reproducible. So this is the area. So if we go to substrate map, Callum, on the 3D map. So substrate map shows us we should be somewhere near the exit site and close to that central channel. Now we're going to do. Can you do the Sarah pacing 600, 600, 300? Okay, just going to get some better contact. Okay, try that. Beautiful. Okay, guys, so do you see that? So that's reproducible. So in real time, live here, Prague rhythm, we've done a deep 600, 600, 300, and you can see beautiful decrement on the A spline and, in fact, across the board there. All those signals, visually, I can eyeball this and see that they're all functionally active and decrement where we are. Let's just try a pace map from A1, A2, so we'll straight pace. Beautiful. Okay, and let's see what that looks like. Okay, so we're a bit low there. So you can see that we're probably exiting somewhere different. If I just come slightly higher towards the there, so try A1, A2 there, please. Okay, let's have a look at that. Okay, so you can see that, yeah, so we probably need to be a little bit more basally.
Do you mind if we ask another
question?
So
I'm going to go back. Yeah.
So we heard Dr. Tang's lecture about the ILM and the area of slowing during sinus rhythm, and you have this information from your map. Now the question is whether the deep map can help you increase the specificity of, so the ILM alone, areas of slowing, it's more specific than just low voltage. So we get that, and I think that became like pretty standard. The idea behind the deep is that can you narrow this even more or expose other areas that are not seen with ILM alone? So can you show us the substrate map during bi-V pacing and compare it to the deep map pacing and how they compare to each other as far as areas of slowing?
Yeah, Ela, that's a great question. And I think one thing that we'll need to do, which probably takes about 5-10 minutes to do, is to turbo map the last beat. So what I'd like you to do is to come back to us so we can show you that difference. Now, what I can do is from our, we can show you the ILAM map. So we can go to our late potential map as an activation map. So this is bi-V pacing lat map, and we're going to set the purple to the latest component. So we bring the purple down. Good, okay. And we've got the white. So if you just extend the white to the left so that we're not encompassing, that's better. Keep going. Beautiful. Okay, hold it there. So look, Elad, you can see there that you've got color bunching where the purple, the turquoise, the yellow, then the orange. You've got 4 color bunching all in that one same area where you can see there's deep potentials. Now, I guess one of my, ILAM is absolutely fantastic, but it does require human visual interpretation. Whereas in combination with deep mapping, it's very reassuring because with deep mapping, the numbers don't lie. A signal either decrements and it doesn't, and you put a manual tag. There's no mapping system at the moment that can automatically do a S1, S2 subtraction map. Yeah, I think this shows you, and we can go to wave speed, which looks at deceleration zones. So we'll go to the omnipolar map. And there, so that's standard setting 0.5 to 1.5, and you do see slowing of conduction in that border zone from that septal scar into the normal healthy area. So can we just pull 2 maps up, please? One with substrate on the right, wave speed on the left. So substrate on the right. So
the ILM map on the right?
Yeah, Callum, that's, there we are, that's better. Yeah, good. So that's the ILM map on the right, wave speed on the left, and you know, whether wave speed is accurate enough, objective enough, but you do get the impression that where you see color bunching of the purple to orange in that zone where the HD grid currently is, just below that you are seeing slower conduction in bi-V pacing. And it's also where these decremental tags, can we put the green tags to surface there, Callum?
So it seems like you have correlation between areas of slowing during bi-V pacing, which is the ILM, to areas of deep, and also to areas of reduced voltage, where the voltage from normal becomes severely abnormal. So there is correlation between those three parameters, right? The bipolar.
Yeah, I mean, look there. Look at the surface green tags. You've basically got a line going from the inferior outflow tract all the way to the anterior LV summit area with green tags and slow conduction and ILAM color bunching. And can we just show where the best pace map site was? There we are, right there. And can we just show the actual ECGs there, Callum? Thank you. So we're just going to pull the ECG up, and you can see the score map was 94%. Yeah. And I think, you know, ILAM wave speed, they're showing us where we're getting deceleration at the exit and entrance sites of SCAR. But what the deep signals also show us is potentially where the channels run within the SCAR. And if I can show you the substrate map on the left, just put substrate map on the left, Callum. Yep. No, I can't see any SCAR. That can't be substrate. Where's the grey scar gone on the septum? Thank you. So you can see that there are green tags that run either side of that channel running down the center of that septal scar. It's like the green tags have highlighted a runway strip.
Remember, the green tags are the areas with deep.
Manually tagged deep potentials.
But that looks pretty extensive, right? Almost all over the border zones, right?
Yeah, so you've got extensive correlating with wave speed and ILAM from that floor of the outflow tract all the way up to that sort of LV summit area, that anterior basal LV portion. But then what wave speed and ILAM haven't shown you are the interesting channel properties within the dense scar itself. And that's where we've seen interesting. Can we just click on, is it possible to manually click on one of those green? In fact, if I just, probably quicker if we go there. So with HD grid, we're now in that central channel. So can you do the, so on the if you just go to the recording system, yeah, you can see that you've got some fractionation at the end of the bi-V pacing there. So Sarah, can you pace 600, 600, 300?
It's very nice. We have to move, before we move to the next case, and we'll come back to you later, can you just share with us what are your thoughts about the lesion sets you're going to create in this case?
Yeah, so Elad, we ablate two things, the VT exit sites defined by best pace map, best activation sites, and we also target all the deep potentials, the green tags. So they will the ablation targets. The best pace map site, where we saw the mid-diastolic potentials in the run of VT, which was in the same site, and all the green tag areas.
Okay, great. So we will be back with you after two more labs we have to go to. So you can go ahead and start your ablation, and we'll be back to you.
So, and we'll show you
go to another lab in IKEM.
Yeah.
To Pierre Jai.
We'll go back to the lab of Pierre Jai.
Can you introduce the case, please?
Okay, so this is a case of CT-guided catheter ablation of ventricular tachycardia performed by Professor Jais and Professor Kautzner. And let's see the next slide, please. Let's see the next slide. Okay, so this is a 73 years old male patient. He's pretty sick. He had ischemic strokes twice, and he had a peripheral artery disease. He's in atrial flutter now, and he had a myocardial infarction quite long time ago with subsequent surgical revascularization. He got single chamber ICD in 2013, and you see his echo parameters. He has a very dilated ventricle with severely decreased ejection fraction of 20%. He also has severe secondary mitral regurgitations. His pain score is 23, so he's a pretty high-risk patient. Let's see the next slide. This is his ECG on administration. Here we see the atrial flutter in the atrium, and we see the scar on the inferolateral wall, and there's also amputation of the R waves in the precordial leads. Can we see the next slide? So this patient had in last 9 months, he had like 52 episodes of VT ranging from 130 to 220 beats per minute. That was terminated by ATP. There was no ICD shocks, but unfortunately we don't have the twin lead QRS morphology of the clinical arrhythmia. And we will show you now what we've got so far.
Yeah, so the patient, I'm very jealous, I have to say, because Joseph got the photon counting CT scanner before I could in Bordeaux. So congratulations on that, guys. We like using CT scan to define the scar of our post-MI VT patients, and this is the beautiful images they did here in Prague, where you can see the wall thinning by the yellow arrows pretty well. Next slide. And we also did some late enhancement that I'm going to show you on a reconstructed model. Next slide. I'm trying to keep ablating because the patient is moving a lot. So with CT scan you get a very detailed exact anatomy, as you can see here, with the aorta, the coronary arteries, the veins. The leads have been segmented, it's the white thing, and in green is the left phrenic. And next slide. More important is the rendering of the scar, and you see it's very heterogeneous. So what you're looking at present time is a color-coded wall thickness map. And the dense red is 1 millimeter or less, and then it goes all the way to the bright yellow, that is 5 millimeters. And this heterogeneity is useful to identify some CT channels that are existing between areas where the wall thickness is so impacted that it's very unlikely that there are any surviving bundles. And it's true when you are in the range of 1 or 2 millimeters likely. So next slide. This is late enhancement. It behaves pretty much like late GAD with MRI. And you can describe also dense scar and gray zone. Dense scar is the dark blue and lighter blue is gray zone. And next slide. And then you can see the contour of the red. This is the white lines, not the dots, the white continuous lines. This is likely areas of, some poor connection acting as a barrier during the VT, most likely. And so then you can plan your ablation strategy, and these are the lines made of tags. Hopefully we can translate that into ablation tags. And so we get some idea where to ablate. in this area where you have the orange color are more in the 3-4 millimeters range, where likely you have some surviving bundles that could act as the CD channels. So this case has been very challenging so far. This patient has been moving a lot. We had to repeat the map. Also, it turned out not to be very easy for the technician to do the registration from the pulmonary artery. So we had to complete that with some mapping of the LV, which is unusual. We typically don't need it. Could you paste from here, please? And so we've been... No, you won't see that because we don't have it. We just did FAM.
It was just FAM for registration, not for...
For merging with the CT.
Yeah, for merging, but not for...
Yes, please. Could you paste? We have 10 grams contact and no capture, which I'm happy with. So here we did deliver on this area CT channel. That is pace here, please. That is, to prevent some perimitral circuit, and which have loss of capture. Is it 10 milliamps that you're using? Yeah, 15. Okay, very good. So it's you can stop. It's very reassuring, and so I'll try to here we go.
It's a huge atrium, a huge ventricle.
Everything
very
is
difficult,
huge in this patient.
very difficult to reach even with a steerable sheath.
Yeah, it's a large curve, agilis, and yet we struggle a lot. And you see my lines; they don't look like lines, unfortunately. But yeah, I'm trying to compensate for the technical difficulties in manipulating. But the idea is really to straight away go after these CT channels with no attempts to induce prior to the ablation, and
we had such a noisy signal now.
Yeah, turn off this red.
Is it because of pacing? Maybe is it?
Yeah,
still
because
on?
of the pacing is on. Yeah. Can you turn off the pacing from the ablation kit?
Oh.
Okay.
Okay.
No, it's better. Yeah. Perfect.
Good.
No, there are some
Thank you.
nice late potentials, in the channel again.
And so in fragile patients, as this patient definitely is, it's sure.
Yeah.
It's nice not to even try to induce before.
Can you explain to us how do you map to get a good merge between the CT and the electron anatomical map? What structures do you? How do you do it? What's your workflow?
Yeah. So typically we would do that just with fast mapping of the pulmonary arteries when we go transeptal. But today it proved difficult. I'm not entirely sure why. So we did some extra mapping of the LV using a pathway catheter, which we typically don't do.
Beautiful signals here.
Yeah. Could you pace here? Because this has been ablated, so. Yeah, it still captures.
That's
very good.
Very good for
almost
fitting.
So
this
is interesting because.
It's not exactly, but
one of the reasons why we sometimes still have inducible VTs after ablation is insufficient ablation of the channels. That's the most common reason, and so we're trying to avoid that by checking for loss of capture. And another benefit of looking at wall thickness is that you can choose for a given channel the area that is likely most vulnerable, because it's the thinnest in the channel. So the likelihood for getting complete lesions and durable lesions is higher. Well, hopefully. And again, some manipulations issues. I'll try to get back to the area.
What's your settings for ablation in this area?
Yeah, it varies from 30 to 40 watts, and the duration is in fact also something we play up with quite a lot to get deeper when needed. So for example, the line we did that connects the scar to the mitral annulus, we only use 30 watts, but for longer duration to penetrate deeper. And so if you look at the channels that are in between the areas of likely block, you see that most of them are parallel to the mitral annulus, and this is typical of myocardial infarctions. I'm not sure why. Could we pace from here, please? Check for non-capture. Yeah, thank you.
Yes.
One bit was captured, was it?
Yeah, this brought on.
Yeah, yeah.
It's more or less similar like
absolutely.
VT we used to have. But it's not exactly the same, but
it's very impressive how wide the cuirass is in VT and during pacing, by the way. It's quite spectacular. Yeah, over 200 milliseconds. That's quite something. It's a very diseased patient and heart. And could you pace again, maybe? Is it?
Go 15.
Yeah.
Even.
Yeah.
No.
Good. Okay. So this is probably better. Thank you. So maybe this CPU part is okay. Now I have not done anything on that little channel right there. Yeah, there are no ablations here, so I'll do a little bit here as well. Oh, nice signal, by the way.
We moved a little bit.
We're in contact.
Yeah, you are getting lower. Yeah.
Yep. Is the patient doing well?
Je v pohodě? Dobrý. Yeah, he's okay.
He's okay?
Zvednout tu mapu trochu. Yeah, there is something. It's not so dense scar anymore here on the eyes.
Okay, well, according to signal, it is quite altered.
Of course, but it's, you see that it's not transmural, it's already sort of subendocardial.
So I have a big contact here. I will probably not do a long delivery.
So whitening.
Yeah, I'm not surprised. 50 grams.
You can see ice, and you see the whitening of the tissue.
They don't have ice.
Can we show ice image? I'm saying that they can show it.
Yes, now yes.
Still have a...
But our, not something else. From our place.
Not
live.
From the... Okay, here. Yeah.
Oh, it already disappeared? No.
Could you paste from here?
Yeah, here you see the whitening.
Yep.
Yes,
could you paste from here?
Just under papillary muscle.
Yeah, we capture here.
Very long SQRS.
Yeah, very long and very wide.
It's a very septal already going to the septum, so it's okay. We should ablate here more. Yeah.
I'm trying to, change my position a little bit here to reduce the contact somehow. Okay, we'll do it here. And so once we're done with these channels, I'll show you the superior and lateral aspect of the wall thickness map, which I suspect is telling us that the patient is likely going to be inducible after a channel ablation, because he has a very heterogeneous aspect of the scar. So it seems that when you have a abrupt transition between the scar and the healthy tissue, you don't have this inducibility after channel ablation. But if it's a very progressive, then you might see it, and we may have to further deliver in this region. You know, we'll see if.
Can we have again the map?
Right or not.
Trošku posunout tu. No, trochu, aby mi to ne... No, no. Děkuji.
Could you... Oh. Again, it's a bit of a challenge to maneuver in this patient. I'm not sure exactly. Could you rotate the map?
Yeah, we are close to it.
Yeah, we're getting close. Thank you. Oh yeah, here. Oh no, not yet. I have to go more lateral. Sorry, more basal.
I think we are stuck.
I cannot. Yeah, I'm trying to redo the approach to that region. Yeah, I'm stuck on something.
Yeah, you need to pull back a little bit, catheter.
I did by a few centimeters here. That's better, right? Could you rotate a little bit so that I'm sure?
Yeah, that's
where we are. Yeah,
actually.
Yeah, good. Okay. Yeah, very abnormal signal again here, particularly during the ectopics.
We have suggestions. Yep. We will let you mapping and ablating, and we will get to Homolka lab for AFib case. What do you think?
Hi guys. This is Robert and Elad. Can you please share with us your case?
Yeah, can you hear us okay or no?
Yeah, we hear you excellent.
Hello?
We hear you excellent.
Okay, perfect. So I think we're going to show a presentation. Pablo's going to describe the case, and then we'll go live with the case. So Pablo, please introduce us. We see you, Pablo. You can talk.
If you hear me, here a review of another case sent from Homolka Hospital. It's going to be a pulse field ablation of atrial fibrillation combined with high-energy radiofrequency ablation. We have here a 62-year-old male with a history of persistent atrial fibrillation since January last year. He had one electrical cardioversion in May last year, but the atrial fibrillation reoccurred quickly despite medical therapy. The patient suffered from exertional dyspnea, has a low CHA2DS2-VAS score of 1, and arterial hypertension, obesity, and on echo, we saw enlarged left atrium, lower ejection fraction, and mild mitral regurgitation. The patient is on anticoagulation with rivaroxaban and on medication with propafenone. Here you see the EKG, 12 lead EKG from yesterday, which shows AFib. The CT scan, which we will show you later. And the ablation strategy here is to use the Sphere 9 mapping and ablation catheter with the Affera mapping and ablation system. This patient is in the clinical FDA trial. It's a roll-in patient, so the patient is not randomized. And we will start with the pulmonary vein isolation and lines, and then the rest will depend on the procedure.
Okay, good. So hopefully you guys can still hear us. I think we'll take you through what we've done so far, because we have done a little bit of work. But just to introduce the technology, maybe we could put the live camera on this screen over here. I mean, sorry, on the system over here. So this is the actual mapping and ablation system. So this is the RF generator, the PF generator, and the mapping system itself over here. And then up here, I don't know if you can show them the, it's just up, yeah. So right over here is the actual pump. So this is an irrigated ablation catheter. So the catheter itself is, maybe we'll just show it on fluoro. So if you guys, can you show them the fluoro on the side screen? Actually they can see it there. Let me do a quick cine here. Okay, so what you're seeing in terms of our catheters that we've introduced, yeah, you have an ICE catheter that's sitting in the right atrium. Hopefully you can see that. There's a coronary sinus catheter. It's just a standard catheter. We have a deflectable sheet through which we have the Sphere 9 catheter. That's the lattice tip catheter. Notice that the catheter, you can just see the little dots at the tip. That's actually the lattice itself. And each of those dots represents a node that allows for electrogram acquisition as well as a temperature control. The energy is delivered from the whole lattice tip, not just the dots. So the whole lattice delivers either RF energy or PF energy. So with that, let's just take you through what we did. So now if we can go to the main screen, please, the preset 1. So let's go to the main preset 1. So what you have there, obviously, not obviously, but that's the mapping system itself. Just to take you through it, you see the main system, the main screen with the PA view and the superior view. PA on the left, superior on the right. On the far left are the electrograms. So at the top you have a CS electrogram and an EKG. So at the top, there's a CS, which is what we're pacing, and then the EKG lead. And then those white are actually the electrograms from the lattice tip. The T is the tip. D1 through 4 represents 4 distal electrograms, and P1 through 4 represents 4 proximal electrograms. And at the bottom, you see a running screen. We've already, maybe if we have time at the end, we'll show you how the map is created. But I think for right now, we're just going to show you that we've already created a map, and we're going to go from here. So initially, the patient came to us in atrial fibrillation, and we did the initial part of the procedure in AFib. So that voltage map that you see there is actually in atrial fibrillation. So as we manipulate the catheter in the chamber, we can create an anatomy. Actually, maybe we'll just show them a little bit. Can I just do that?
Yeah.
Go, just create a new map for a second. I just want to show just a few minutes of it. No, do a new map, actually. Yeah, do it from scratch, yeah. I just want people to understand exactly how it's done. Okay, so yeah, go ahead and start. So what happens is, as you manipulate this in the chamber, it actually acquires the anatomy, so that's the FAM-like, or whatever we want to call it, as well as the voltage. So you can see there, and that's how it acquires it, okay? So hopefully that's clear in terms of how the anatomy is acquired. Now, we can show more later, but I just want to give people an understanding of this. Okay, now let's go back to what we had before, the initial voltage map, and hide this one. Okay, so this is the initial voltage map. Once we finish the voltage map, and actually let's rotate around. Let's show them one of the really, I want to actually show them, okay, so there's a right middle vein as you see, right there, right superior, right inferior. Let's go to the left side. That's where it gets interesting. Here you can see the invagination between the left pulmonary veins and the ridge, the left atrial appendage. You can actually see that ridge nicely. Let's rotate that down, Wojtek, or up, just to really show them how. One of the nice things about the system is it allows you the capability of creating these invaginations, which I think is a much more realistic sort of description of the left atrial anatomy. And then after this, then Jacob did a PVI. Let's show the lesions, please. Now the way good, perfect. Now the way the protocol is written, we do pulse field posteriorly and RF anteriorly, and there's different regulatory reasons why we're doing that. We could do pulse field throughout, as we and others have demonstrated. But anyway, the green dots or discs represent the PF, the pulse field lesions, and if we rotate around, keep going all the way around, And then the red dots there, or orange, I suppose, those are the RF lesions, okay? By the way, if you rotate back up, Wojtek, notice that even though this is anterior, those are green, these are PF. And the reason is because the anterior aspect of the left inferior, even if you're trying to ablate anteriorly, the ball is thick enough that sometimes you get heating posteriorly where the esophagus can be. So it's just easier and safer to do it that way. Okay, so we did the isolation, then we cardioverted the patient. And then with CS pacing, as we're seeing here, we did another voltage map because, well, we were just waiting. So maybe we can show that, Wojtek. And so this is what we have. So you can see the left veins are isolated. The little yellow and blue on the far left, that's just far field stuff from the appendage, and we've proven that. So now it's time for us to isolate the right pulmonary veins. So what we'll do, yeah, do we have a paralytic pushing?
Can you tilt that PA view down a little bit?
A relaxation pushing? Yeah, okay, good. So now what we're going to do is we're going to start ablating right about here. Actually, why don't we do RF anteriorly a little bit first? Okay. So show an REO view. I want to start with RF.
REO and?
Yeah. Okay, let's come out a little bit more.
Can you hear us?
Can you hear us?
Yeah, we can. Go ahead.
Can you share with us a little bit what are the parameters for the PFA as far as we can tell, we can share, and what is the distance between lesions you target and so forth?
Yeah. So let's just zoom in there for 1 second. I want to show them a couple of things. So there are a couple of things you notice here. First, you see the 2 electrodes on the catheter shaft are blinking. That's because the shaft, the agilis, the deflectable sheath is now covering. So that's where you know that the agilis is very close. The second thing, if you're deflecting the tissue more, you can sort of see, you see there the white on the tip? That's a electrical impedance-based contact sensing algorithm. So now we know that we're actually touching tissue there, okay? Look on the far left, you see the electrograms there. And again, the various electrograms. Now we're going to deliver RF because at the very top of the screen, you see where it says RF 5 seconds anterior. So each lesion is going to be a 5-second lesion. So let's just get going now. Okay, he just stepped. Okay, so now what you're seeing there is the blush of heat on this. So that's the heating. And notice the electrograms have just gotten, they just got ablated. So now we're going to go to the next location. That's a little close. So let me explain those 2 numbers that we see. The L represents the location or the distance from the current catheter tip to the closest ablation lesion. Okay, so that's 3-4 millimeters away. The P represents the distance from the catheter tip to the posterior wall. Okay, if you look on the top-down view on the right, you can see sort of a hatched region on the posterior wall. That's just an automatic algorithm that says, okay, you're getting posterior. It's not exactly validated, so to speak. It's just a way to help the operator sort of understand when they're getting too posterior if they're not paying attention. Now, the other thing is, and this is what Elad, I think you were alluding to, if you look between the 2 lesions, you can see that there's a gray area, okay? A gray line. So those 2 lesions have a gray line in between them. You can go ahead and ablate down.
Yeah.
Okay. So, and what that means is that the distance between these 2.
Disabled.
Oh yeah, we just have to reset that. Okay. So what that means is that the distance between those 2 lesions is close enough that it says that you probably have contiguity. Now, how does it say that? It's basically just a user-defined metric. So at this point, we set it to, I believe, is it set to 5 or 6 millimeters, Wojtek? 5.5. So if one lesion is less than or equal to 5.5 millimeters from the adjacent lesion, you'll get a gray line. Let's just for fun, let's put the next lesion a little further away so we can explain to them what happens. So yeah, so let's say he puts the lesion even further away. Yeah, right there, that's good. So let's say Jacob puts the lesion here as he's going to. Notice that the distance is 11, 12 millimeters. Now it puts a blue line because it says, okay, your lesions are further away from each other than what you said you want it to be. Just an easy way to to visually see where one lesion is relative to the adjacent one.
Tilt up, please.
Okay.
But just to clarify, Vivek, and correct me if I'm wrong, it's not just the visual distance between center to center lesion, but it's the distance between the areas that got heated the most on each lesion. Is that correct?
So that's right. Let's zoom in and make this keep going though, Jacob. So this is an important point that Lad's making. So if you look at the lesion, let's go ahead and have him make a lesion. Notice what you'll see is you'll see the red disc, but you also see a gray ball. Okay, go ahead and move. Go to the next location. You see a gray ball behind it. You can keep ablating, Jacob. You see a gray ball behind it. The ball, you're getting back a little bit. You want to get a little closer. Yeah. The ball represents the actual location of the actual lattice tip. The red disc, or green disc for that matter, represents or is placed on the surface based on where the greatest amount of heating is. So if there's a lot of heating inferiorly, it's going to put the disc on that side. So what Elad pointed out is exactly right. It's not the centroid, but rather the center of the discs. Yeah. Now let's switch to PF. So to switch to PF, Jacob is going to double click, and notice on the top of the screen, he just went from RF to PF. And then we can look on here. Let's just look on ice. One of the nice things on ice is you can see, hopefully you guys can see ice there. The lattice tip is very easily visible there. You can see it right there. Okay, let's go. Now, notice during the lattice ablation, you still see a small blush of heat because, of course, when you dump that much energy, you're going to have some amount of ohmic heating. But in some ways, that actually helps us because it tells us that, well, we actually did transfer some energy into tissue. If, on the other hand, actually, let's just do it. Just go in the middle of the chamber once. Undeflect. Just go. This is completely in the middle of the chamber, right? And we'll just deliver one PF lesion. Yeah, we're not touching anything. Okay, good. Okay, go ahead there. When we do this, basically you see nothing. And the reason is because we're not touching anything, and you get no blush of warmth, let's say.
Can I see a little bit more of the right-sided veins?
No, go PA and just translate, please. Good. Now the other thing.
You can see this on the screen. You saw in the last lesion you had a minimal, maybe 1 degree or a couple of degrees of increase in temperature, but while he ablated just in the middle of the chamber, you did not see this. So that gives you an indication that you are in contact.
Yeah, that's right. Notice there again, very nice. This is great stability that Jacob has right now. Notice that the tip of it. The tip was just sort of white, the white dot. He has good contact with the tissue. And actually, let me just show it on ice also. There. Actually, Toshi, you want to just keep showing them people the ice.
Tilt down, please.
Let's see. So hopefully, wait. No. Show the main screen. I want all of them. Let's go to the preset one, please. They need to see what's happening. Good. Okay, good. You can put the camera, yeah, great, thank you. Now, the way the protocol is set up, again, this is a roll-in case, so we're just using the lattice tip system. In the actual protocol, it's a randomized trial, so it's randomizing people who have persistent atrial fibrillation to ablation either using the lattice tip or the Cardo system with the STSF catheter. And it's a multi-center, multinational study. In fact, I think tomorrow Joseph and team are going to show one of their roll-in cases also. The other nice thing about the lattice tip is the tip is somewhat compressible. It's hard to appreciate that when it's in the body, but basically because it's compressible, even toward the roof, you can sort of position the catheter, and it's pretty good at staying stable. I mean, it's not perfect, of course. It doesn't have glue or anything, but it's able to be quite stable and allow you to make the lesion and keep stability. I think that's probably the most important aspect of this catheter, is that you're able to get a relatively wide footprint of RF or PF, whatever you want to do, and you're able to do it relatively stably.
There's a lot of visual gap there.
Are there questions from the audience?
Yeah, it's okay. I don't know, if you want, you can.
Any questions?
I'm sorry, I didn't hear that question, if there was.
It's usually normal. It's about 300 to 400. Yeah. Can you share with us what are your plans for this case after you complete the PVI?
Yeah. So actually, how much time do we actually have in this case?
You have another 5 minutes live with us, and then we can come back to you after a while.
No, go ahead, finish. Okay. So you know what we'll do is we'll probably just wait for you then. So what our plan is, after we finish isolating, then we're going to do a roof line, because I like roof lines. And we're going to do a mitral line.
Anterior, please.
And then we're going to do a CTI line and get out. So the way the protocol is written, now, of course, if there's an inducible flutter or something like that, we're definitely going to ablate that. But assuming that there's not, that's what we'll end up doing.
So a mitral line you'll do empirically.
The mitral line I like empirically. I like mitral lines. I mean, I tend to agree with Pierre that a mitral line that's well done, I think, to me, the mitral line is the equivalent of the CTI line of the other chamber. Meaning, let me be more clear. When there's disease anteriorly in the left atrium, that's when I think a mitral line is probably most indicated. If the whole atrium is quite healthy, then I think there still might be reasons to do it in a persistent patient. But I think your sheet this far back, Chief. I feel less compelled to do that, let's say. And I think, again, our experience with this technology has been that we can make mitral lines quite reliably, safely, with good durability. So I feel comfortable doing it. We're probably isolated, right? Actually, I wasn't paying attention.
There's a little gap there.
You know, one of the nice things about this catheter is because it's very small electrodes, you can do very high resolution mapping. I mean, I don't know if we're going to have any typical flutter, but if we did, it would be really nice to sort of show you how quickly we can map it.
It seems like your vein has been isolated a few lesions ago.
Yeah, absolutely. I mean, that's typical, right? Well, you typically see... actually, let's show them the electrograms, please. If you can switch to make the preset 2. Yeah, let's just stay right there. Yeah. So if you can see there, so the white in the middle, the white in the middle, no, actually, we don't need to do remap. No remap. You can see that there's, Elad said there's dissociated potentials right there. Can I do something here? I want to just show them. Let's do a quick, because they have to leave in a couple minutes, so I just want to do a quick roof line, because I really want to show you mapping, and you'll see the utility of it. So we're going to go, this is PF? Okay. So we're going to do a quick roof line. As you'll see, it's pretty good at making roof lines. It's actually extraordinary at making roof lines. I mean, I don't think we've ever had a non-durable roof line with this, with the most recent waveform. Oh, Elad, you asked about waveforms. I have no idea. We did, as you know, we've undergone a waveform resolution.
To put you on the spot, so if I'm being asked tomorrow, I can refer to your answers without getting into trouble.
No, look, the reality is I don't really understand what exactly is in the waveform. I'm actually relatively, I mean, I just have no idea. Nobody tells me any of these things. What I can tell you is that this is the optimized waveform that we use. So we've gone through 3 different waveforms that I'm aware of. And this waveform has had excellent durability results. And I think that you and Jake are going to talk a little bit about that tomorrow. Let's do a quick remap. I'm going to do one more lesion here, and then we'll do a remap. So I want to prove that this roof line is intact. So what we'll do is we'll stop pacing. Show PA view, please. Let's do a quick remap here. Okay, so we just stopped pacing. Now we're in sinus rhythm.
Junctional.
Oh, junctional, great. That's annoying. I guess we can get some atropine, right? Can we get, no, then we'll just get more junctional probably. You know, he's been in AFib for a while, so it's very possible.
Okay, there you go.
Oh, there, okay. Now we have a sinus mechanism. Okay, so what we'll do is we're going to map in sinus. Let's increase the gain of the electrograms, please, on the mini electrodes. No, that thing is, that's garbage because we don't have any electrograms yet. But just, so what we're going to do is we're just going to map here really quickly. Notice how it's ignoring, oh, you know what, it just went junctional again. He keeps going back in and out of junctional. Oh, there he is, now he's in sinus again. So, you know what it is? It's interesting. He's been in AFib for so long that just a couple of PACs is resetting the sinus node, so it's going into junctional again. It's funny. Are you acquiring? Junctional. He's in junctional again. So annoying. Anyway, the point is, if he was actually not going into junctional all the time, you'd see how easy it is to map quickly on the posterior wall to prove that you have block. Let's do one more time. Maybe we'll get lucky this time.
You know, Vivek, the other thing maybe it would be interesting to do is to pace from the distal CS and show the vector when you're on each side of the line, if it just doesn't happen to collide.
Yeah, the CS, it's on, yeah, we can do that. Let's do what, so let's do that. Let's pace from the CS, and then we can do the vector. So we'll show them the vector so people understand that.
And the sinus is not very...
Yeah, the sinus is not robust right now.
You said something bad about sinus, and it's sinus.
No, it's okay. Let's do it. So now we're pacing the coronary sinus. He just moved the window over. He's going to show the propagation vector. And let's acquire anyway. We'll just acquire really quickly. Start acquiring.
Just to make sure that everyone just appreciate the vector is basically from, it's a live vector. It's showing at each beat the propagation using those mini electrodes on the catheter. So you can clearly see that the wavefront goes from down up.
Okay, now let's show the posterior, so anteriorly, please. We'll do the exact same thing.
And let's go from the posterior wall. And here it looks like when you stable that it's actually going, that there is a block and it's going up from, also from lower or higher, unless there is a collision.
Yeah, again. Let's try sinus one more time. I really want to show them this. It's just so cool not to.
Stop pacing.
So stop pacing, create a new map.
It'll take a while for it to wake up. Oh, no.
No, his sinus is back. I think his sinus is more robust right now. We're going to do one last one, Elad, and then you can go if you want.
You just said it.
Oh, did it?
Yeah.
Oh, son of a bitch. Okay. You know, if you have a few more minutes, can I just do the mitral line, or you want to go and come back?
You're online, by the way.
On what?
We can hear. We can hear you.
Okay. Okay, then let us just do the mitral line. So you guys set up for the mitral?
So Vivek, we have to go to another lab. Do you mind just saving the mitral line for us when we come back and we can do it at real time together?
Okay, yeah, we can, yeah, go ahead. Go, and then how long before you think you'll come back?
Maybe do the CTI in the meantime.
No, I'll do them both. It'll be fine. I'll wait for you guys.
We will be back shortly. So maybe let's go to the lab of Fermin Garcia and see if the PVCs are still suppressed.
I think Fermin's here with us.
So can we go to IKEM?
No,
sorry, to Homolka, the second lab in Homolka?
Because they are probably finished. Just to see if there's a recurrence or something like that.
Can we switch to the other lab in Homolka? You okay?
Okay. So they already finished.
So are the PVCs back? We guess they're not back.
Okay, so we have connection to
Are we here? Okay, all right, that's great. We're back.
To deep mapping.
So guys, we were doing the deep mapping. So what we've done here on the map is we've turbo mapped the deep potentials. So Callum's going to show you on the template on the inside X screen we take a match of the S3 beat, the last pace beat at 300, and we do a last deflection map. So anything purple comes up late. And you can see that, can you put the substrate map side by side as a reference? Make them as dense as you can. And you can see that the deep potentials are highlighting that purple area, that blue area is highlighting nicely that central channel. So this is really the area of interest here. Now, if we just go to the back of the left ventricle, so if we spin the map round, you can also see that because we're pacing from the RV apex, the lateral basal LV is also coming up late. And this is where we really need to work to get a true map that shows you the decrement. So whilst we were mapping, something happened. We did a VT stim. And if we go to the electrograms page, Sarah will show you the VT stim.
Can we slow down the review screen?
So the VT stim now, if we just change the sweep speed to 50, great. So with 2 extras, we induce monomorphic VT. Can we see the 12 lead ECG? 12 lead? Great. So here it looks like a left bundle, and it's an inferior septal access. So we started doing a VT activation. Can you show the mid-diastolic potentials? So straight away we're mapping the isthmus that we think is interesting.
Not the other one.
And she's going to go, so Sarah is going to pull up the mid-diastolic show. And so when we put the HD grid onto that isthmus where we saw those deep potentials and that central channel through the scar, we see beautiful mid-diastolic potentials there. So we do an entrainment as well. And with the entrainment, we can see we're entraining from the D spline. And if we just go to the 12 lead page first, Sarah, can you show the 12 lead ECG of that page? And so we've got exact entrainment. We've accelerated the tachycardia to the pacing cycle length, and the PPI was great. So we started doing a VT activation map. Can we switch to the propagation map on the inside X? So this is our VD activation map, and we see got reversal activation of this channel, whereas the initial VT1 that we were mapping, the activation was from the low septum up to the anterior basal septal LV. Now we've got reversal of activation through that central channel, a nice figure of 8 going round. So we're going to target this channel. Callum, can you play the first burn? So if you look at the X screen, we're in VT, and we get our ablation catheter ready. You see power now straight up, and with our first burn, immediately we've got termination of VT. So that proves that this isthmus was responsible for both of these VT circuits. So we're now consolidating, we're making sure we've ablated this isthmus, and again, the deep potentials have highlighted this isthmus like a runway. And so we've ablated those deep potentials. We've done a line across the top where we had slow conduction, both defined by deep potentials and ILAM and wave speed. We were just doing a bit of touch-up burning. So do we have any questions at this stage? No?
There are no
Elad,
questions.
did you get all of that? Was
We don't hear anybody.
I can see someone's arms up on the back row.
It looks like a great case and a great, at least, outcome for now. Are you going to ablate the rest of those green dots that shows deep?
Yeah, Elad, exactly. I think we've got to future-proof our VT patients. You know, we think this is the clinical VT, but this patient's had a redo VT ablation. This is a redo from a previous ablation a few years ago. And we found interesting areas on the inferior LV where we had late potentials that didn't decrement and some sort of what looked like ablated tissue. And so in order to future-proof this patient, similarly to ablating potential other conduction corridors, we're going to use these deep potentials as surrogates of conduction channels to try and future-proof this patient.
Very nice. So it looks like you started with ablating the most specific area that correlated with not only with the presence of deep, but also areas where you had longer stim to QRS with the VT morphology, right? And after you eliminated this, especially given it's a redo case, you're going to address with ablation the other sites that shows potential channels.
Yeah, absolutely right. I think if we look at outcome data based on just ablating the clinical VT, we know historical work from Delabella's group, from multiple groups, has shown that if you purely target the clinical VT, there is a higher risk of recurrence than having an endpoint of non-inducible clinical and non-clinical VTs. And so these other decremental sites have the potential for non-clinical VT. And so that's the justification for us to target those areas as well. And interestingly, Elad, these areas correlate with where the ILAM map was and where we're seeing deceleration zones. And this is why when we were talking earlier about all these different methodologies, ultimately I don't think we're ablating too far away from where the different methodologies would be telling us where to ablate.
Very nice case. We have to move to the rest of the lab, so congratulations, and we'll let you finish your ablation lesion set, and we hope to see you at dinner. Okay, thank you.
Thanks, guys.
We'll get to
maybe Pierre.
Pierre and can we have another lab in IKEM?
Hello, hi, Joseph and Pierre. Can you hear us?
Yes, we can.
Great. So it looks like we see that you made a lot of progress because we see red dots on the lines with the white dots.
Well, trying to, we still struggle a bit with some manipulation issues, but yeah, we're making progress. And we also, you know, I mean, this kind of very large substrate, I wish we could use the Sphere 9 catheter with electroporation. That would really be a perfect match with the type of ablation we need in this patient.
Maybe better even with high energy RF, the latest tip, because that will create centimeter lesion footprint, so that would be beneficial.
Yeah, but we're typically in the range of less than 5 millimeters depth, so I don't know. Could you, by the way, measure that on the ice on some? It's
about 1 centimeter is the distance between these markers, so it's approximately close to 8. I would say 8 millimeters, 10 millimeters. This thickness here.
Yeah, then you may be right. RF may even be better.
Guys, did you see abnormal potentials in those areas you are ablating, lavas?
Plenty. I mean, it's hundreds of them.
It's amazing that whenever you go to the channel, you see nice late potentials or lavas, low amplitude. It really fits. In many of these channels, we got very nice potentials. The problem is that there is extreme dilation of the atrium and also the ventricle, and it's really difficult to manipulate the catheter because the sheath does not support properly, and it's it's really a nightmare to get good contact in some areas.
Are you using a retrograde or transeptal approach?
No, transeptal approach, because the patient is quite sick. And he had strokes and he had peripheral artery disease, so we did not want to risk. Retrograde would be better, obviously, for this area because it directly goes to that area. But we have transeptal here, even transeptal. We had to struggle a little because both atria are really, really huge, and the patient has pulmonary hypertension, and it's really advanced heart failure.
To give you an idea of how dilated the LV is, the end systolic dimension is 77 millimeters.
Yeah.
So it's really huge.
We can just see the size. We can just see the size of the catheter relative to your FAM to understand how big this chamber is.
Good. Good. So we lost capture in this region, so it's probably.
But don't forget that FAM is not complete map. It was mainly mapping septal part. This lateral part was not completely mapped, so it's even bigger in reality than the FAM map.
Right, right.
And you see it rather on the CT image.
You were looking for a nice signal. Look at that. Do you see them?
Can they see moving signals? Can you show them this
yeah,
map
we see those beautiful signals.
Sorry, map,
yeah.
the recording from Pruka. Okay. It looks like a VT almost, huh?
Yeah, slow.
And this is in one of those channels, right?
Oh, it was irritation.
It is, yes. It is in the middle of the scar. And so I'm not going to burn here because I don't want to, you know, kill everything. I will stay on my in my ablation plan, but you have plenty of abnormal signals everywhere. It's really rich, and not a surprise, of course.
Pierre, do you have the any outcome data comparing elimination or targeting those channels to complete lava elimination strategy?
No, so we don't have that comparison yet, but we have a randomized controlled trial that is about to start with a control arm with conventional ablation, and then in the study group this approach. So we'll get that, and we'll have this kind of data.
And I guess that your hypothesis, or I don't know, at least my hypothesis is that maybe by ablating those channels, you'll be able to apply less ablation and with more specificity and eliminate to the same degree or even better the risk for recurrence. Is that right?
Faster procedures, hopefully. Typically, we have, I mean, over the last 40 patients we did, well, that was in my presentation, I suspect, but over the last 40 patients we did, we had a mean of less than 2 hours ablation procedures. And again, the vision I have is that the day we cobble this strategy where we have a much faster identification of the targets because of imaging to a superior ablation like the sphere, then we'll probably have VT ablation becoming easy and fast with less risk so that it's scalable. Because one of the things we are not doing well at present time, I think, is offering ablation to enough patients. So we probably need some easier procedures that can be implemented also in private practice centers that are at the present time considering this ablation as too complex or too dangerous to be part of their program.
Okay. So Pierre and Joseph, maybe in the meantime we'll go to Homolka and we'll come back to you. Is that okay?
Sure. Yep.
They are waiting us with mitralismus, maybe.
Hi, lad.
Oh, Dr. Garcia, we thought you were in the restaurant already waiting.
We had a 30-minute waiting period, and the one on the right, just keep that image there. Just keep the X-ray, the Pruka. You're both me. I don't think they want to see me in both. Basically, we had shown you two screens, and after 30 minutes, we had no recurrence of PVC, so we took the patient off the table. Don't know if there is any questions or you want anything to review or anything Petrus is doing another case, and I'm happy to answer any questions you have.
I will just use one phrase that I remember from David Callans. And when I see you ablate, sometimes I wish that I had the PVC that you could have ablated in me, but I guess I don't have so far. So, anyone have a question? So, Ante?
Yeah, that was at the right side. Is the beginning of the case.
1 second. There is one question for me.
Yeah, of course.
Dr. Rani.
My name is Antonic from Croatia. I congratulate you for the straightforward case. It was a single lesion, as I realized. So your energy setting was 40 watts, and you kept, and your intention was to keep there for 3 minutes. It's very unusual approach, at least in Europe. And what is the basis for this? Because as far as we remember from the basic work, the RF lesions do not grow after 40 or 50 seconds.
Fermin, did you hear the question?
Yes. Yes. No. Can you repeat it? It was something about why did we do 3 minutes with 40 watts, I guess, instead of doing a 20 watts longer duration lesion. I start at 40 watts. I think that the key here is to having close attention to contact force and the vector of orientation. I start at 40 watts because I like in this location to get into the tissue faster, and I know if it's going to work or not. We had completely PVC elimination in 5 seconds, 4.5 seconds. And then we did a longer lesion, monitor on ice. I look at the lesion kind of developing. I think certainly the tissue became white. If I had a thicker tissue and the idea is to try to penetrate deeper, I might attempt certainly what you are describing as a lower power, longer duration lesion to try to get deeper in the tissue. And I think more than anything, deeper in the tissue without the risk of a steam pop. So you start at a lower watt setting. This is what I've been doing for the PVCs that I suspect are closer to the mid-myocardium based on mapping. I understand what you're saying. I guess either way would work as long as you're monitoring your application carefully to prevent any complications.
So I think for me, the question is, in this case where you had elimination after 5 seconds, you know that you don't need to penetrate so deep. So why did you continue and do such a long lesion?
Because if I had exactly an idea where this was coming from, maybe I would have stopped at 60. A lot of times we see that when you stop early, then you have late recurrence of the PVC, maybe with a different exit and a different QRS. So, I mean, I think certainly 3 minutes sounds like a longer lesion than 60. I don't think it's particularly long. I think you get one chance. I think that coming back after you move for the catheter move creates then a second lesion on top of edema. I think you sometimes get one shot and you want to have a good lesion. What we didn't do is put any more lesions. We stopped there.
Yeah. Now, and the other thing I want to say, Auntie, is that for me, looking on the ice all the time. Now, we used to guide ablation when many times we don't look with ice. Now, you can see if you have if you have a pop about to occur, you will see this on ice too. So I think as long as you look on ice,
this is not a workflow that European electrophysiologists will follow easily because they don't use ice. And right. and that manner, I know, Dr. Garcia, are you using ablation index? What would be the correlate? What do you mean? What do you think? Have you ever tried to calculate what would be the correlate on the ablation index of your lesion today?
It's probably more than 600 for sure. I also move a little bit. It's not that I'm in one spot constantly. I get a sense of going in and out and right and left a little bit in that area. Again, this is not because you're just trying to do subendocardial. You're trying to get into a deeper layer of tissue that has a three-dimension aspect to it that I don't know how to define it. If I were exactly sure where I was, I agree with this concept. I'm not staying in one single spot. I'm not moving widely, but probably if I also use the same systems that you use to define if you move, I would get 3 lesions in one spot automatically, and maybe it will be 400 on each spot. The reality is I'm not moving. Certainly, if I were to stay in one single spot, I don't know, I can ask them what was the lesion index, and they can tell us. I don't know. It's certainly higher than 600. I get your point. Is this too much ablation? I mean, I can tell you that in the top of the left ventricle, it's hard to define what's the right ablation index. The main problem would be here. I'm not concerned about perforation. If you have a good catheter orientation, you would get a stim pop, and you're watching constantly. I mean, this from what I've seen doing in other places, it's kind of in between. I don't like to start at 20 in this area. I don't like to start at 70. I start at 40. I don't know if there is a right number.
No, the other thing I want to say is that, we actually, one of my fellows is going to have an oral presentation at HRS exactly about this, the relationship between ablation index and lesion depth in the ventricle, because ablation index was not validated for ventricle. And I can tell you there is little correlation between lesion depth and ablation index in the ventricle, and surely less in scar tissue. So I think the old-fashioned way to think about it, the power and the duration and contact is probably the way to go. Okay, Fermin, thank you very much. I think we're going to move back to Vivek. So thank you, and we'll see you later. Congratulations.
Thank you so much, and congratulations to everyone.
Okay, so it looks like we're ready for a mitral line there.
No, absolutely not. Not now. Hi, can you guys hear me? I think you're seeing us.
Yeah, we see you and we hear you.
Okay, fantastic. So this is about, let's show a PA view again really quickly, please. So this is obviously, you saw the PVI, you saw the roof line. Now we're going to focus on the mitral. So if we rotate, I'm just going to cine really quickly. So you can see there's the ablation catheter. You see where the CS is. We're pacing from CS 1-2. So we're pacing from distal CS. Let's rotate to the right a little bit, please, and zoom in on the mitral. Wojtek, zoom in more, please.
Great. So we see that your timing is pretty much 0 to the catheter, so you'll be able to show when you block.
If it blocks, which is better, it should be quite obvious. If it doesn't, that'll also be quite obvious. Notice on the if you look at the colors, the voltage, you can see where the mitral valve would be, right? I mean, the colors are pretty clear. You can also see, Jacob's showing you on ice. There you can see it. You can see the lattice tip. If you counterclock, this should show them the valve. So it's right there. You can also see the CS catheter. Can you guys see that? I don't know how easily that comes out, but anyway, it's there also. So now we're here in this position. I like this position to start with. Can they see everything? Yeah, okay. So, and then you notice on floor I'm using a direct approach, and I'll come back to that. So we're set to PF. So I'm going to start with PF here. And notice there's a small blush of heat that you saw there. I'm not moving. The electrograms look good. They diminished. Zoom in and rotate a little bit for me, please. Okay. Even though the electrograms are fairly diminutive here, I still want to ablate because, with PF, I think there's some adjacent stunning that can occur with each lesion. So because of that, I'm very conservative here, especially in the mitral isthmus where the tissue can be quite thick. Now look, if you actually look, it's blocked already. You can see that right there? Hold on, I'll just go, just for fun, let me just show it to him over here. So if we look on this side, you can see it. Show the vector just for fun. It'll probably reconnect. We're not done yet, but. So now if you look at where's the vector?
We see the electrogram at low resolution here.
So. At low resolution here.
Oh, you say low resolution? No, look on the side of the screen. Actually, show them preset 2, please. It'll be obvious. Preset 2. Dva. Okay, there. So now you can see the CS is pacing, right?
Yeah.
And then you can see the electrograms on this. And if I go to the other side, I'm going to move this down here. Obviously, the electrograms are very close.
That's beautiful.
That's beautiful.
Okay.
That's beautiful.
Let's go back to preset 1, please. I'm going to finish this line. Okay. Wait, what's going on here? Okay, so let's rotate to the left for me a little bit. Rotate, yeah, good. That's not stable. See, I didn't like that one lesion. There was not much blush of heat. It actually came blue because it didn't see much heat, so it was unhappy there.
But I think everyone needs to appreciate in a difficult posterior mitral line, 3 lesions of a total of 15 seconds achieve the block.
Yeah, I think that's better. This has some blush.
I want to do one more right here, yeah. I think just like with RF, I think stability is absolutely key. Now, just for fun, let's do a quick map just to show them how we do the map. So during CS pacing, let's just do a quick map here. So this is the remap function. It comes up black like this, and then we're going to start. Just do activation, please. And then we can just go around. Show me a little more anterior, please. And it just becomes obvious here. You guys open up the window so that it's... Oh, that's V. That's the problem. Okay, fine. I had to come back here. The purple there is the ventricle. We just set our window a little bit too generous. That's okay. So Wojtek just fixed that window here. Okay, good.
Let's just go below the line.
Okay, show me posterior there. Let's open up the color window. It's all purple. Okay. So you can see it's blocked there. The second thing we can do is let's paste the ablation catheter. We're going to paste from the ablation. Now, when we paste, we can paste from the whole lattice tip, which is what we're going to do. Let's go to preset Dva, please. So you can see, we'll show it the Pruka in a second. We're pasting from the ablation catheter. Notice the coronary sinus activation. It's completely reversed. And again, if I fluoro, so it's live, actually I can even bring the CS a little bit closer. Okay, there. So again, it's completely blocked. I hope that's obvious. Okay.
CTI.
Now, before you guys leave, because I know you have to leave quickly, I want to do the CTI. So we'll go back to the right side. Show me the CTI. I want them to see this. Okay. Show them ice will be nice, actually. What's that? Okay. Now we're going to set up the window. Yep. Yep. So you can see ice. And actually, let me just show them on ice. So if I clock the ice, there's a point, and I'll show you in a second. So you can see the tricuspid valve, and I'm looking a little lateral as I clock, as I clock, as I clock. A little bit more, that's the septum is coming in. So I counterclock. It's right about here that I like to make the line. So you can see the line will be right here.
If you can see on ice there, you can see the PDA right there.
You see the coronary right there. It always makes me a little nervous.
You see the coronary.
But it's true, of course, with every single ablation.
It's amazing how lucky we are.
I just think, yeah, I mean, we've never had a problem. With this technology, or with any of the others, I guess. Though I should say, it has been reported. I know there's a couple of case reports out there of damage to the coronary and blah, blah, blah. Okay, so we're set. So let's see. Can they see everything? Yeah, okay. So you can see it. If you look on the side of the screen, you can see the side of the affair screen. You can see the pacing. You see the pacing spike. You see the electrograms. That's the atrial electrograms. And then you can see the far field V, which is the respiratory phasing, you can see it come in and out. So we're going to start ablating here. Notice I switched to RF.
1 second. Everyone see this? Yeah, no, we have it. Okay, yeah. Okay, you can go ahead, sorry.
And then on the screen, let me just show you. We have a LAO inferior. That means we went LAO and rotated all the way up, okay? And then on the right screen, it's a typical RAO view. Those are the typical views I like to use. So let's just show this. Can you just show this to them? Okay. No. Here we go. Okay, now we're going to start ablating. Notice the tissue is getting white as this gets ablated. And then let's do. Notice the blush of heat on this. One of the nice things about this is that you have the whole thing is ablative, meaning even on the back part of it, it's ablative. So it's actually really nice. So now this is a good position.
You can see how you cover the entire CTI with like 3 or 4 footprints of this lattice.
Now come back a little bit further. Yeah. It just blocked there. So if I counterclock here, you can see now. Let's throw the vector just to show people. No, let's do a vector. I don't want to do all that. So this is the vector showing the activation here. Again, it's only a few electrograms, but it's certainly not going, like if I go on this side, the vector is going to be pointing right through in this direction, obviously. Is there anything more proximal than this? I don't think so. You think that's real?
Right there.
All right. Jacob doesn't believe it, so he wants one more lesion here. Okay, and that's the CTI line. You want to create a map and show them? You want to just create a? Okay, let's go ahead and create a map. Yeah, it's probably worthwhile. They haven't really seen how the map is created. Do you guys have time, or I don't know how you're doing?
We have a minute or two if you want to summarize the case while you do the map.
Actually, it's really boring to map here. I want to show you something else instead. I'm going to just take the catheter out. I want to show them the catheter. Can you just flush this guy? So can you show the live? We'll go live on live. You guys, can we go to the live camera? I want them to see this catheter tip. Can they see it? Can you zoom in a little bit? I just want to show them the tip because I think it's really sort of neat. If we just focus on here, not on me. Yeah. Okay. Hopefully you can see the tip. So the handle, they're frozen. Okay, now I can see it. Okay. So notice the tip, and it's compressible. Hopefully you can see that. Is that obvious?
Yeah.
Okay, that's the main thing I want to show. I think that's such a critical aspect of it because it gives stability. You can zoom out just a little bit. I want to show them the handle and everything. So this is a bidirectional catheter. Zoom out, Prosim. No, the other way. Yeah, good. And so it's bidirectional, so it deflects in one direction or the other direction, of course. It's interesting, it has these controls. So there are a couple of things, we didn't use them today because there was too much going on, but you can actually start mapping, stop mapping, and a few other little things that are sort of neat. This is an 8 French, actually I think it's, it's an 8 French catheter, so we've put it through a typical deflectable sheath, or non-deflectable if you so desire. So that was really, I just want to show the catheter itself. And then, let me just show, and the final thing we will do, we just want to verify that everything looks good. So there, no pericardial effusion, of course. And yeah, I think that's good, right? Okay, good. Any final questions or comments?
Any questions from the audience?
Are they there?
Questions from the audience?
Everyone's ready.
Maybe they're all at dinner.
No, so thank you we have 15 minutes if you want to put another patient on the table. But otherwise, thank you very much. Excellent case.
Next door, actually.
What? You have another one?
I do have one next door.
So okay, thank you very much.
So thank you very much, guys. Maybe we can go now to IKEM, to Pierre's lab.
Can they connect here?
We are back to IKEM. Can you hear us, please?
Yes, we do hear you very well. And so we are quite happy with what we did finally on the lateral wall. Trying now to, get this more apical part of the scar, which turned out to be a bit of a challenge. Sometimes the schist is too short, and when we advance it to have more length with the catheter, then everything goes off.
Yeah.
So
right.
we're struggling, but we'll get there eventually.
From what we see here, 90% of those lesions are done, right? Like most of those lines look covered.
Again, the lateral part of the scar, I think we did pretty well. Even though some areas I'm not very happy because we still capture. So we have a efficacy of the RF deliveries issue. And I'm not sure how to solve that. Again, I wish we could have a better ablation tool. And I'm dreaming of combining the Sphere 9 to the image-guided ablation strategy, particularly for this kind of patients with a huge substrate. It's really challenging. So Joseph is not trying to get to the apex with the ablation catheter.
The problem is it really bends down all the sheaths.
And again, it would be easier probably with a retroaortic approach.
Yeah, of course.
But for safety reasons, we did not consider that option.
But where I am now, can you bend it down? No.
Here we are.
Lateral.
The lateral wall, yeah.
Okay, where are you now?
Inferior lateral.
Okay, this one. This is what I wanted.
So we now have a large loop.
Můžeme to ukázat, kde jsme pořádně.
Jo, teď
jsme na septum, můžeme to otočit na septum. Můžeme tu mapu otočit na septum, OK, perfect. Show me the scar on septal area.
And we transiently got a VT, which morphology was possibly compatible with this apical scar. So, wow, we really would like to ablate there as well.
Kde jsme teď? Jak se na to koukám? This is inferior wall, or
inferior.
Can you give me some normal projection? Like, okay, so now to the left and a little bit up. It's amazing. There's no way to get to this apex.
Yeah, it's extremely difficult to get there. We've been trying hard. We'll find a way, but it's frustrating.
I lost again this position.
It's very frustrating. So sometimes you at the end of a long day or a long case like this one, you think that, maybe radiosurgery is a good idea for some of these patients with extensive substrate and particularly dilated heart.
No.
And because again, the patient is very fragile. So getting closer, good. But you see, it's very unusual that it's so difficult to reach the apex. Typically, it is pretty simple.
So here we are.
Yeah.
The signals here are pretty big.
So here we are in the
let's get started here. You may want to turn on the ablation.
Můžeme ablovat?
It is so difficult to get there that...
Cože? Já můžu klidně, mě to neabluje.
And we lost ablation apparently. Not sure why. Here. Now it works.
Tak můžu?
Okay, so we're right in the channel. 30 watts.
We could
for a prolonged. I don't know if you can increase the contact a little bit, maybe, but.
Yeah, I will try.
Okay.
I was a bit afraid.
Oh, very good. Very good. Okay.
To lose the position. So
I know. I understand. At some point in time, we'll pace map here, maybe, to see what the morphology looks like.
I bet that there will be not big delay in this area already because there is not much coronary.
Agree. And even on the CT scan, it's not the big one.
Can we pace from here?
There is no delay.
There's almost no delay.
Can you show us how it looks like in 12 lead?
Yeah, we had some apical VT, but can we show that apical VT?
It wasn't quite like that.
Yeah, I think so. Yeah, it was a lateral, and Can you put this slow VT to the window on the right side, please? No, do pravýho okna dát pomalou komorovou tachykardii.
It's one of the last two we've got. May I suggest that we keep ablating in the meantime, because we.
Yeah, that's it. It looks similar.
No, I think it was another one.
No, this one, the other one.
Yeah, we've seen something that was
negative 1, 2, 3.
Yes, absolutely.
And also negative in V4, V5, V6.
Yep.
It's going down the impedance.
Impedance is okay.
But gradual is still going.
Yeah, that one.
Yeah.
That one.
Okay.
Yeah, could you compare that to the pace map we just did?
Put it to the right window, and then we will pace from here. It's not the same.
No. I don't think it's the same. Or you can pace now.
You can pace now, or you can, but put it, okay, now, and pace now. Okay, show it. We are too apical now.
Yeah.
That was more.
Yeah.
But somewhere in between this and the scar.
Yeah.
Can you rotate to the left? So I will try to map this slightly.
So the thing is,
maybe we can pace here somewhere.
We may have to connect the apical to the lateral scar.
Yeah, this I think will be better.
Yeah.
See, it starts to.
Yeah, absolutely. So could you reduce the transparency so that we see the wall thickness better? No.
So you don't.
Yeah, lower because it's.
Zvednout trošku tu mapu.
We have less thickness, so it's more likely to work. Yep.
Doprava trochu. Yeah, doprava.
Yeah, we'll have to connect that to the lateral scar through the scar, and that's a quite long line.
They are. We are on, or
I don't know. Do you still hear us? Hello?
No questions?
No. I don't think we're online.
No, you're online, guys. We see you well.
Okay. Are you still there?
Yeah. We are looking carefully.
We don't know. Yeah. Okay, so it's very difficult really to manipulate here, but we had one VT from this area. We try now to connect with the previous lateral scar. It's really enormous ventricle. Very, very difficult to with this enlargement of the atria as well. It's very complicated too. And I have full length of the catheter already in the body. So
just to understand, you are ablating now on the thicker area between the thin area on the apex and the thin area on the septum. Is that what you're trying to?
It's somehow connected. Could you show us the wall thickness map better, without possibly for a moment, without the Carter map itself, just the wall thickness? Thank you. And a little more toward the apex. And lift it somehow? Not that much, not that much. A little more? Yeah, exactly, yeah. You see it's connected on the inferior aspect. And this is where we should place the lesion to have a chance to get transmurancy. But I don't know if you see the X-ray and the crazy shape of the catheter. It will give you an idea of why it is so difficult to manipulate in this patient, because it's really a snake catheter we have now.
So can we ablate here probably? No? Yeah, I think
And as Joseph pointed out, we clearly don't have a proper sheath for that kind of patient. Now, this is very unusual in my experience. I don't know if in Prague you often have this kind of patients, but
not very often.
It's very unusual in my experience, for sure.
If he wouldn't be so high risk, I would go retrogradely for sure.
Yes.
I still prefer to go retrograde, but we had a lot of bubbles now.
Yeah. For this region, it would have been much easier, no question.
Oops. Let me see now where we are. Otoči tu mapu doprava.
This is more septal now.
I know. I will pull it back. Here we have some nice signals. Proč si přetáčíte tolik?
Can you show us where we are?
Can you show me where we are? Up? A little bit up?
And more lateral, probably.
Original map, there was no line connecting those septal scar to the apical scar, is that right?
Yeah, that's absolutely correct. But I think we have to, there is a channel there which has not been drawn by the radiologist, but it's there, between the apical scar and the apical dent scar and the lateral. They're clearly connected by an area where we are in the 3 millimeters range that we have to take care of. It's very unfortunate because it's a long line, but we really have to do something here and ablate that region. The thing is that this patient is, you know, the amount of work we typically have in 2 or 3 post-MIVT cases.
So, you know, it looks like you have a very good strategy, and the imaging is very nice. What you're lacking, and that's not your role to show here, is an ablation, you know, adequate ablation tool. That's what is missing here. It's not the diagnostic tool, it's the ablation tool.
Generally thinking, if you look at the footprint by a Sphere 9 or a Farflex, they're about 1 centimeter, and so most channels would be, you know, ablated with one site delivery, and of course several repetitions if you use pulse field ablation. But this is really the way to go in the future. Well done, Joseph.
Look, there, like the audience would like to see some signals from this channel. If you can show one example before you ablate, maybe.
Can you show them the signals, please, from running screen?
We see them very well. It's unfortunate that you don't.
We see them on the proximal now.
You have to ask.
Yeah, exactly. And it's fractionated on distal as well. It's just that we don't see it very well. Look at on the mechanical bits. It's very fractionated on distal as well, with some very early signal from time to time.
Yeah.
So I hope
Don't
that
take so many points there.
Doron Halev is going to watch this case in, well,
Yes.
you know.
Electrogams doesn't
I
seem to
persuade
go
him
away.
to start with VT ablation as well.
Yeah, that's really a perfect tool for what we need for VT ablation.
Stop.
I think the only thing, Pierre and Joseph, is instead of sphere 9, maybe we need a sphere 15.
Yeah.
Oh, not necessarily. I think we did some of these ablations with sphere 9, with RF, and it was pretty good. I mean, the footprint is nice, and the lesion size is also good. Můžeme to zvednout víc?
Not sure where you are here. Yeah, okay.
I'm connecting to that.
So I still think sphere 9 would work for most cases. And even if you need, in this case, you probably need two sites to connect the apex to the inferior lateral scar. Yeah. But it's nothing as compared to the nightmare we are experiencing at the present time.
I just want to make sure that the audience understand when we are looking at the sphere 9 is the catheter that you saw used with pulse field ablation in the ventricle, in the atrium, in Homolka. But this catheter can also deliver RF and PF, but in RF mode, as compared to the 30 watts we're delivering with the thermocool, you can deliver 400, 500 watts with a much lower current density, so you can do it safer without causing a steam pop. So you can hit so much more tissue, volume of tissue, safely.
Yeah, very good, very good. The other aspect, Elad, and I know you noticed that as well, is that the sphere 9 gives you an amazing stability. Yeah. It's deformable, and it kinds of anchor in the tissue, with some of the tissue being, indented in the latest structure of the catheter. In some areas here, it would have been super helpful. We had some stability issues as well. From time to time.
That's what I like about the catheter, because it's a rough surface and it will stabilize on the tissue, not sliding, and it's also softer, so you can hook it really on the tissue with some mild pressure.
Yep.
So it's really nice catheter, and maneuverability is excellent. I mean.
Pierre, can I ask you one question about the imaging?
Sure.
So we know that the heart is three-dimensional, and you have all those papillary muscles, and those papillary muscles tends also to be many times involved with the scarring. Now, the maps that you show with the channels and like this, it looks very two-dimensional, right? At least from the views you're sharing. But there is any way that the music software can actually show like the real three-dimensionality, including all the crevices inside the chamber, which is more complex than, just like an outside shell.
I'm impatient to get this kind of software. We're working on that. There are some technical challenges. If you don't want to wear special goggles, there are some challenges to be able to give you some 3D rendering while, having a 2D screen, basically. But hopefully we'll get there. And I think you're right. It would be really nice. Yeah. I've seen some prototypes. I'm not entirely happy with where we are at present time.
So maybe you can just share with us what you're going to do. So you plan to continue this line of ablation and try to induce?
Yes, absolutely.
Okay. So I think we'll just at this point conclude and thank you for the case, so you can actually focus on getting the hard work done without having us watching you. I think we understand the concept, we understand the challenges. There is any conclusions from your end that you want to share with us?
Yeah, well, that's a somehow atypical patient, very fragile, in whom working in sinus rhythm makes a lot of sense as compared to inducing different VT morphologies. We've seen, I think, I don't know, 5, 7 morphologies, so the alternative would have been to map under some kind of hemodynamic support. But I still think that if you can, get rid of most morphologies by this kind of substrate-based approach, it's better for the patient and probably safer as well. So hopefully we'll be able to complete these ablation lines and reach non-inducibility, or just one morphology left. As I told you, when you have a very progressive transition in the wall thickness, as it is in the lateral and superior aspect in this patient, it's likely that you can have some fast and polymorphic VD coming from that periphery of the scar. So I prefer having scars where you have an abrupt transition to healthy tissue. This is less arrhythmogenic, but we'll see what we get. And hopefully
I fully agree with this approach that we also try to do, especially in high-risk patients, rather than put them in general anesthesia and do on pump. It's better to do, in my opinion, as much as possible of substrate modification without inducing. And this is a much lower risk. And the complication rate is generally low, I mean, in these patients. I cannot get higher contact here because it's sliding already towards the apex if I push a little more. But, I mean, we already did some work on this channel in between the apical area and the lateral wall, and it's a huge scar on ice, visible also, as you could see probably. We have some episodes of whitening. We had some pops also, so we don't want to be really risky.
One last point maybe, Elad, is that because you get imaging done before VT ablation anyway, it's recommended. And when you get this kind of 3D model twin of your patient, then you can really anticipate how much time you will be in the lab and how difficult this is going to be. And I also think that from a planning perspective, it helps. You could even think about, centers who are not keen to treat such an extended substrate that would refer straight to a academic center maybe.
Yeah, absolutely right, Pierre. And also I think it's really impressive how these sick patients right now tolerate all of this procedure with complete hemodynamic stability because you don't have to induce and do a lot of pacing maneuvers. So I think that's also important. So thank you very much, guys. Actually, they want us to go to the second lab in IKEM. There is some update over there. Yes. So thank you very much for sharing the case with us, and we really appreciate your hard work.
Thank you.
Thank you very much.
Excellent.
Okay, we're back with you guys.
Yep, great. So we've wrapped up. Patient's gone back to the ward. Just wanted to show you a couple of things. So you can see on the VT activation map, the green dots are where we manually tag those decrementing evoked potentials. Our ablation lesion set, 15 minutes of ablation time, covered all those deep areas and the mid-diastolic isthmus. And at final VT stim, if we just flip to the ECGs of the final VT stim, we induced clinical VT very easily with 2 extras. And here at the final VT stim, with 3 extras to VERP, no further clinical or non-clinical VT inducible. So we're happy with our endpoint for this patient today.
That's very impressive, and a very little amount of RF, I must say. Any questions from the audience? Oh, can you show again the final lesion set, the map?
Yep. Yeah. So on the system, the Inside X system at the moment, you can see the red tags are the final lesions. And the green tags are where we manually tag the deep potentials. This is the VT isthmus. So we had, you know, the decrementing tags here, Elad, really highlighted the isthmus here like a runway. And so we ablated...
just to explain to us, this propagation map is in VT?
Correct. This is a VT activation map.
That's the
so
VT activation.
we had sustained... So we had sustained monomorphic VT. We had two VTs in this case. The first VT was using this isthmus, the same isthmus. However, conduction was from inferior to anterior along the septum. And in the more sustained VT that we managed to do a full VT activation map, the isthmus, the same isthmus, was being used in the reverse direction from high to low. Yeah.
That's very nice. So I must say that this activation map looks to me as a partially intramural or even epicardial involvement, right? Like you have a breakthrough from this isthmus earlier than when it comes from, you know, from the entrance, right? Do you? Does it?
Yeah,
does
I think somewhere in the inferior aspect, the exit site was probably mid-myocardial because the V1 looked more like a left bundle morphology than an RBB pattern. And so when I see this with septal VTs, I always think this has to be at least mid-myocardial, if not an RV exit site. But, you know, I think the point is, you know, there are multiple areas where you can target the isthmus. And, you know, by targeting the isthmus along the whole length, and we know Delabella's group has published really important activation map data showing that if you ablate VT activation map isthmus and you can define the whole entrance, mid, and exit part of the isthmus, your success rate is much higher than if you just target one or two parts of the VT isthmus. So, you know, I think we had at least two parts. We may not have had the exit site perfect because of the mid-myocardial nature. Elad, I completely agree with you there, my friend. But I think we had enough of the isthmus to be able to target mid components and also entrance components.
Yeah. Congratulations, great case. I think we learned a lot from this case. And also we learned how, you know, how you streamline the whole protocol of DIP, which seems very labor intensive, but it seems like you can create the DIP map while you create the substrate map just by acquiring you know, different bits at the same time. So thank you very much.
Elad, just one final point, Elad. You know, I always say to my fellows, my trainees, invest in the mapping and then the ablation is easy. And so for this case, we spent 1 hour mapping with parallel substrate and deep and 15 minutes of ablation. And this patient had an EF of 25%. So this was, you know, a sick man. So yeah, no, thank you very much. Hope you all enjoyed the case back in the auditorium. And, you know, we will be around, Peter, myself, Callum Fenton, who is my CP, who I never go anywhere from home without him. So we will always be around for questions later on or tomorrow.
Very good. So thank you very much, and I think that concludes our session. Thank you very much for everyone for staying late, and we will see you guys at dinner. So.